Boy, that's a challenge, talking about payment policy and keeping you on the edge of your seat. I also want to comment that if any of you don't know the work that Dr. Flinter has done in Connecticut and you have time, you should track her down because she can make any of this stuff very exciting and has done enormous things in Connecticut. And so we don't have you as a panelist, but the work that you're doing would be fabulous. I want to thank you for inviting me back here. This is my alma mater, so it's really been great to see how it's changed and also meet lots of the folks that I've seen over the past number of years. I'm also an alum of a Robert Wood Johnson and National Academy of Science Health Policy Fellowship. So thrilled to be able to be invited to come and talk to you about what the work that we're doing at the federal level. I don't have any slides because they are difficult to clear. So I will tell you that the three things I'm going to try to walk through so you can kind of hear as I'm going forward is I want to talk about the movement from fee-for-service to value-based care and the opportunities that that is bringing to do a better job addressing social determinants of health and what that means for nursing. Second, the fact that this value-based purchasing movement, I think, has what has spurred a lot of the work that we're doing now paying attention to social determinants of health. And last, what this means, I think, for patients, what it means for nurses, and what it means for the health of the nation. So as a nurse, I never dreamed that I would be working for CMS, which is the largest healthcare insurer in the world. But thinking back as a nurse, I think about a couple different times that my practice was definitely changed because of some federal payment policy. I was in the emergency room here at Children's Hospital Philadelphia the weekend Pennsylvania changed from fee-for-service to managed care. And it certainly changed the way that we delivered care in the emergency room. We couldn't see them and say, come on back for follow-up, because that couldn't happen anymore. We also weren't told that it was happening, so it was kind of a policy change that was curious to us. The second was the federal mandate that nurse practitioners needed to get direct Medicaid reimbursement. That was not always the case. When that federal mandate came down, it allowed me to start a nursing clinic here in West Philly in Mantua. So that was a federal policy. And last, interesting policy that allowed me to distribute medications when I was working in North Philadelphia, but when I was in West Philadelphia, I had to get my prescriptions signed, and I couldn't even give a prescription. And I say this not because of my experience, but for all of you to think about what's standing in the way of success right now for you. What are some of those specific policies? And they're the kinds of things that we need to identify, figure out what's broken, and figure out how we can fix it. So I returned to CMS because of payment policy and have been, since I've been there for 8 years now, working on the movement away from fee-for-service to more value-based care. And fee-for-service is broken for a number of reasons. And you all know that mostly it's because it's one payment that's tied to a specific provider, most times it's the physician, delivering a specific service, and oftentimes in a very specific location. And because of these deliberate specifics of the payment model, it rewards quantity and not quality. So the rewarding is just doing more and more, and it doesn't matter if the patient is improved. So what we're trying to do is look to new ways of making that happen away from fee-for-service. We don't have the magic bullet yet. We don't know what payment policy is the right payment policy, but we know that we are working towards changing what's currently in place. Value-based purchasing has been smattering for decades. People have been doing it. Kaiser, federal government, has been a little bit later in doing that. But there was a big push with the creation of the Centers for Medicare and Medicaid Innovation, or CMMI, that was created as part of the Affordable Care Act, and that's where I started at CMS. And now with this administration, it has continued. Secretary Azar, Secretary of Health and Human Services, has identified value-based purchases as one of the top 4 priorities that he has for this administration. So we've been seamlessly working to move away from fee-for-service into the value-based purchasing arena. At the Innovation Center, they were tasked by the Affordable Care Act to create and test new models of care delivery and payment reform that will improve quality simultaneously cost-effectively. Not necessarily saving money, but cost effectively. So sometimes just not increasing when the cost of healthcare is rising, but improving quality is definitely a success for the models that are created at the Innovation Center. By law, every model that is created at the Innovation Center has a rigorous evaluation, so we can figure out what's working, what's not working. If we didn't have models that didn't work, we wouldn't be expanding and being innovative enough. So there's a variety of models. You've heard of many of them, I'm sure. Accountable care organizations, ACOs. That was created in the ACA. Shared savings models, bundled payments. All of these, we are exploring the general payment and then tweaks to it along the way. I'll mention one model that is finished and actually has been success. I'm timing myself so I don't go over. That was a model that I worked on when early on and when I got to the Innovation Center. It was called Strong Start, and it was a model looking at how we can decrease prematurity. And they identified 3 different models of care that the evidence had started to show that there was a decrease in prematurity. And one of the 3 models was statistically significant, that it improved care in a number of outcome measures: low birth weight, C-section, prematurity, while also being statistically significantly a cost savings. And it was care delivered by midwives in birth centers. And so by doing this rigorous evaluation on new models of care delivery, we now can say with CMS support, this is something that we want to promote, we want to expand, and we've been working with our states to try to adopt this model and improve the model and figure out how we can scale and spread some of these successes. So that's just one example. But it's an example of how when we start to see what's working, we realize it's not just by going to a doctor's office, going to a hospital, and the care that delivered there. And I think it was this understanding that if we really are linking payment to outcomes, we can't do it in the traditional way. We have to look more broadly. And now I've been thrilled that we are spending a lot more time and energy looking at what we're doing to address social determinants of health, how we can support that, how we can get reimbursed it, and other kinds of policy levers that we can do to try to help states and providers do a better job addressing the social issues, and therefore improve outcomes that then we tie to the payment. So in Medicaid, social determinants of health was a little bit of an easier and a good place to start, because Medicaid by its design is very flexible. Medicaid, as you probably know, it's a state-federal partnership, with the feds paying between 50 and 75% and states between 25 and 50%, depending on poverty rates in the state. And so as such, we work with states. We certainly allow states to come to us with all sorts of great ideas. You'll hear many of them from Carol from the point of view of New Jersey. But by and large, the flexibilities include housing supports, transportation, non-emergency transportation, food supports, housing renovations, all sorts of stuff that states are allowed to do. Not all of them take advantage of all of those things, in part because it could be expensive. They may need a state legislature to allow that to happen. They have to come up with their federal match. But there's lots of flexibilities that have been inherent for years in the Medicaid program, and we are looking to see how we can clarify that, how we can help states move along that continuum. And there's all sorts of really interesting models that are happening at the state level. We're also doing this in Medicare as well. So Medicare Advantage, which is the Medicare Managed Care Plan, has recently started to acknowledge flexibilities there for folks who are complex. And as we look to who the Medicare Advantage patients are, about 70% of them are complex. And so allowing additional flexibilities for the Medicare Advantage programs to be able to look at housing and look at some other things if they can improve the quality of care for those patients. As Margaret mentioned, there's other things that we're doing, like the Support Act. The Support Act was, so it's not just the executive branch. Congress is also very much aware that these are critical aspects of health care, the social issues. And in the Support Act, which is federal legislation that look to increase the way we help folks deal with substance abuse and opioids, there are housing supports in there. There are clarification on what we're doing with transportation, how we're making medications more available. It doesn't have to be tied to specific services that we've seen them before, but allowing more flexibility as to where folks get this. And it's an enormous piece of legislation if anyone's interested. But it's an indication that everyone is now understanding that we cannot improve the health of individuals. We can't improve the health of communities unless we start to be able to address the social determinants of health. And so last, I'll just talk just a little bit about what this means for patients, what it means for nurses, and then what it ultimately means for the health of the nation. So in terms of patients, one of the things that I think is a big takeaway that I'd love to hear more thought about is the importance of measures. If we're tying payment to an outcome metric, then we need to figure out what those measures are. We need to make sure we've got the right measures. We know everybody plays to the test, and if you say that there's certain measures that you're going to get paid on, we can imagine that those measures are going to get better. So we want to make sure that we've got the right metrics and we're measuring the right things. We also want to make sure that those metrics are measuring things like nursing interventions. When we're doing certain interventions, are we tracking that those interventions are actually improving? Who's deciding which measures go into the payment? Who's at the table deciding that? And also, if we identify the need for a measure, who's at the table designing those measures? There's all sorts of opportunities, I think, here for students. I keep saying getting data to doctoral students and other students that are looking to have big projects. These would be enormous areas that we would love to see more work being done. Another really exciting area there that's really early is linking data. So we oftentimes see when we're trying to address social determinants that the intervention is in one silo, but the outcome is in another one. And so the way to track that is to link Medicaid data, for example, with early Head Start, with food stamps, with some education. So we can start to see when we do an intervention in one place, what's the impact elsewhere. And that's another, I think, huge area for learning, for researchers, and for anyone that's just curious and can get their hands on the right data set. And we're trying to get our Medicaid data out to a broader population. The second, what does this mean for nurses? I think you've heard at the first panel all sorts of wonderful ideas that have come from nursing, using nursing, and this is an opportunity to support the work that they're doing. One of the things that we try hard to think about at the Innovation Center is we're not just creating a new payment model de facto. Fee-for-service is broken, another one might be just as bad. We want to make sure we're creating a payment model that supports the kind of care delivery models that you heard talked about this morning. So the Nurse-Family Partnership with decades of research, how do we make sure that there's payment models that we can look to, and we're working with states to try to support that. We work with HRSA on some joint guidance because they're providing some payment for that. How can we augment that? Also, other ideas, just to bring up an idea that came from a nurse, at the Innovation Center, we funded Sarah Zanton and her work at Hopkins. And she, as a nurse, made sense to look to frail elders and do home improvements so they didn't have to go to a nursing home. A lot of this stuff doesn't have to, the elegance is the simplicity. So she's created Capable, which is a model that brings nurses and handymen into homes, helping folks stay and age in place, which is where folks want to be, as well as savings millions of dollars to our nursing home and moving along. And she's been able to now take that as one idea and scale and spread it using some Medicaid programs to be able to support in other states. And last is just the moving the health of the nation, that by changing the payment model, we are now finally being able to spend a little bit more time and energy looking at prevention. Prevention has been hard to pay for, almost impossible in a fee-for-service model, but where we're now looking to improve the outcome of diabetics, we have to move upstream to think what it is that we can be doing to prevent adverse effects. What are we doing to prevent asthmatics? We can go into the home and we're doing environmental scans. We're looking to see how we can get those kinds of interventions paid for. How they can be part of a total cost of care model. And many of these are ideas that came from nurses, are delivered by nurses, and I think it's an opportunity as we explore this next version of the future of nursing is to better understand why more of these models aren't being scaled and spread, what can we be doing to identify, and then look to see if we can eliminate some of the barriers to be able to have nurses and what nursing can bring to the health of the nation and maximize what it is that we're doing. Thank you.